Namaste everyone. Today I am talking about laryngeal infection. Of them, most important are acute laryngitis, acute laryngotracheobronchitis, and acute epiglottitis. We go one by one. First of all, we discuss about the acute laryngitis. Definition wise, I am just talking the important concept here for the medical MBBS student and AMS ENT people. Okay, acute laryngitis means inflammation of the laryngeal mucosa. This what is the cause here? As it's viral. What happened after that? That lead to hoarseness and voice change. So inflammation of the larynx due to viral. What are the virus here? Virus here, just I highlight here. See, not new one. This virus are same one rhinovirus. Remember easy? Nose rhinovirus. Influenza virus and para-influenza. These are coming from the decade. Adenovirus also from the nose. If you remember that much, it's okay. Bacterial rare. Don't tell in the exam that bacterial. Non-infectious cause if you use voice more, and there is a smoking irritant. Irritant can cause laryngitis. In exam, most of the examiner focus in this virus, okay? Rhinovirus, influenza, para-influenza, adeno. My suggestion, till first influenza, para-influenza, then go rhino and adeno, okay? That is most appropriate way answering the exam. What is the pathophysiology? That is not much important, but here, yes, mucosal edema there, hyperemia of the vocal cord, okay? Same thing, whatever we discussed in the definition. What are the clinical features? If there is a laryngeal inflammation, there is a swollen. After that, voice must be changed. That is hoarseness of voice. So you have to come with hoarseness of voice first. There may be sore throat, dry cough, dysphagia, maybe fever, but you come with the hoarseness of voice. This is the most common one. Yes, you can, how can I diagnose this kind of disease? Is indirect laryngoscopy, which can do in the OPD setup. There is a red edematous vocal cord. Normal look is lost, normal loss of luster. These are the indirect laryngoscopy. IL is indirect, is also called IL, okay? IL examination, ideal, whatever you tell, ideal or IL. These examinations are indirect laryngoscopy examination. This is not an investigation. Very confirm. Investigation is direct. Investigation is here. Investigation is direct laryngoscopy. Okay. So, what are the difference between indirect laryngoscopy and direct laryngoscopy? There is a, you have to remember 4 or 5 difference between these two. So, investigation is direct laryngoscopy. Indirect laryngoscopy is examination. First, you have to concept clear in this area. Okay. How you treat the acute laryngitis? There is a edema, so we have to need the rest, especially in vocal cord. Larynx need voice rest. You have to take the steam. If there is a pain, analgesic, antipyretic. Antibiotic, viral infection, no antibiotic. If there is a huge suspect bacteria, yes, you have to give antibiotic, avoid smoking and irritant. This can develop later on chronic laryngitis, vocal cord nodule, and polyp. Next topics, simple topics, easy topics, fast, quick topics is acute laryngotracheobronchitis, Croup. How can we remember Croup? This is also viral inflammation of the larynx. Here, infection can go trachea and bronchi. And this is narrowing of the children. Then examiner can ask, what is the age group? Here you have to tell at least less than 6 years. If you come with 3 years, that's okay. That's great job. Next, what is the common? Again, here remember para-influenza virus. Influenza virus. Here coming same organism as the laryngitis. But there is a chance of respiratory syncytial virus and measles infection also there. But again, most common is para-influenza virus. Here, little difference. What is the pathophysiology is there is a subglottic edema that causes narrowing of the airway and giving inspiratory stridor, inspiratory, not expiratory. Some examiner asks, so what kind of stridor develop in the this group? You have to remember inspiratory stridor. Okay. Next is barking cough. Barking cough. They develop barking cough. I already explained age up to 6 years, but it can start from the 6 months to 3 years. Most common age group up to 6 years. So remember, 6 months to 3 years. If you come with this answer, excellent. Next, if you tell less up to 6 years, it's okay. But if you tell 8 years, examiner don't like you. Okay. So barking, seal-like cough. Also, there inspiratory stridor, you come with this. These are the term, okay? You can't change. I can't change. Hoarseness of voice, inspiratory stridor, barking of examiner, seal-like of they want intested seal, S-E-A-L. Or we can make other small tip video also here. There is other sign. What is when it occur worse in the night. Okay, remember. These are the key point we have to remember here. This is okay. Again, I repeat here: 3 months to 3 year, 6 months to 3 year, barking seal-like cough, inspiratory stridor, and hoarseness. It's most common in night. Stipple sign, this is interesting here. This is subglottic narrowing. You can see the stipple here, which is occur in the church. Okay, you can see the church. If you see the church, it is so narrow stepping going up like that. Same sign you can see here in acute laryngitis. If there is subglottic edema, you can see the airway here. This become like a stipple. This is the mnemonic or classical finding in a group. Okay, it can act in the different kind of exam, NMC exam, MEC exam, even United States medical license exam. How child develop? What is the opening mouth here? You can see the infection in the larynx, in the neck. That kind, sleeping in the bed, taking the steam inhalation like that, it can develop this kind of symptom over here. Treatment wise, yes, you can see the oxygen here, humidified oxygen, like this machine, you can give a stimulation good, moderate, it needs epinephrine. Some severe cases, it needs the IV dexamethasone. Hydration is important in any kind of acute laryngeal infection case. Intubation is needed, some severe obstruction, but it is not so. You have to choose the case, okay? Every case is do not intubate. Do by the expert, not by the junior people here. Only severe infection, severe obstruction, you can do intubation. Complication, there is a chance of respiratory failure, secondary infection lead to tracheitis. Last topics today is acute epiglottitis. It is a super hit topics, high yield topics in any exam in ENTH exam. Acute epiglottitis, acute life-threatening inflammation of the epiglottis. Adjacent is causing severe airway obstruction. What is the causative agent here? Haemophilus influenza type B. Especially in the children. Other organisms are Streptococcus pneumoniae and Staph aureus. Pathophysiology, edema of the epiglottis, airy epiglottis 4 lead to respiratory obstruction. Age group again here 2 to 7 years. Highly toxic fluke. Child there, severe throat dysphagia, drooling. There may be hot potato voice, okay? You can see the typhoid position. Child sit like leaning forward like that, okay? This come like this way. And taking the ear like that. So that is the typhoid position. Cherry red, other term you have to tell them cherry red. It is so red, you can see the cherry, so swollen epiglottis. You can see the cherry here. I just put the cherry figure over here. Epiglottis, you can see here, so red epiglottis like cherry. Okay. Finally, the treatment is the emergency cases. Do not attempt throat exam here without airway control. This is the emergency. Even child with loss due to examination by the doctor. Immediate airway managers, yes, control place you can do the intubation, not in the emergency. You have to do the control places like OT, tracheostomy. If needed, you can go IV antibiotic, IP for third generation cephalosporin, steroid in early phases. We can give an IV fluid. Airway obstruction occur, death is inevitable. Abscess formation, late complication. We have to focus airway obstruction. We have to prevent airway obstruction and death of the child. This is the today's session. I think you know much about the laryngeal infection. Thank you. Bye.